Hi, I'm Sarah Dion, and welcome to the Attuned Clinician, where we talk about everything complex trauma and dissociation through the lens of supervision and consulting. In a lot of my videos, I'm going to start out with a lot of questions for you because I want to hear from you as clinicians. I want to know about you. After all, I'm a supervisor and a consultant, and you are important to me, and I want to understand what you need help with. This video is going to be about dissociation. And I'm curious if you, as a clinician, feel that you received enough education within the grad program you went through to treat dissociation. If you received enough support within your grad program around severe complex trauma, if you were an intern and had to face significant trauma, yet didn't feel prepared, or maybe didn't have the supervision behind you to feel confident in treating someone like that. So let me know. I really want to hear from you because that's what this channel is all about. It's about supporting you. Uh, Regarding dissociation, there is a spectrum of disorders, and not people dissociate without having a disorder. So there's DID, dissociative identity disorder. There's partial DID, and then there's OSDD, which is other specified dissociative disorder, which is actually very common among people with severe complex trauma, and yet not well known. So that's one area that most of the time we're not getting what we need to understand and how to keep an eye out for it. And I'm going to start with the ideas around what dissociation might look like in your session. And a lot of these ideas or assumptions are that you will know. And that is just not true. You may know if you know what to look for, but a client can look almost exactly the same and they could be totally dissociated. So that makes it very difficult to know what to look for because, oh well, if they look normal, how do I know? And that's a really good question. Part of that is having a long relationship with the client so that you can get to know them. Unless it's really obvious, it's hard to identify within that first session, second session, because you're getting to know um, them and how these things show up for them, and also if they can report knowing they dissociate. But a lot of people don't know they dissociate. So, some key indicators that there's significant dissociation is going on are within the client's giving of history. And this is really important to ask when we are first getting to know someone who has severe complex trauma about memory. So, with of course, with the people thinking about dissociative identity disorder and what that looks like, and of course, we all know that there's so many misconceptions about it. Um, that of course, they are going to have really significant gaps in memory, but it may not be super obvious that it's DID. So they may say, I just don't remember things. I feel like the week just flew by and I just don't remember Wednesday or Thursday. And that might be about how much they know about it. So we just want to put a pin in it. Like, oh, they do have problems with memory. Or maybe they feel like time is strange for them. Like time just flies by or gets really short, or they are late everywhere. They struggle with, like, seriously struggle with time management and feel like they've never been able to sort that out. Um, and so that's important to put a pin in. That could be different things, but we still want to put a pin in it if this person has complex trauma. So those are indicators that maybe there's something going on here because It's not just memory we're talking about serious trauma and memory lapses. So that's one thing to keep an eye out for. Another thing to keep an eye out for is medication isn't working. It seems like their bodies are medication resistant, and but they keep trying meds, not working. We want to put a pin in that because why? Why wouldn't these medications be impacting their brain chemistry in a positive way? Um, none of them. We really want to dig into that as we go forward because medication doesn't treat dissociation. And if we're trying to treat issues that cause really significant anxiety, memory lapses cause a lot of anxiety because people miss important details, events, meetings, late to work because time just disappeared. So those things create an enormous amount of anxiety, also depression, feel like I'm failing at life. Medication's not going to treat that. So you're not going to feel happier or better no matter what if those things continue to happen and it's not getting better. The medication is a moot point. Um, and I'm not saying not to medicate someone who dissociates because medication definitely can come in to at least keep that person at survival level, their head above water in order to do the work, and many other reasons that I'm not going to get into right now. So I'm not poo-pooing medication uh, because I do feel that it saves lives. So those are things to look, just like putting pins, because if we start to kind of get to know that this is going on, these time things are going on, then as we meet with the client, then we might start to notice patterns, and that will help us kind of figure out, um, when this person might be forgetting the most. One thing I really like to do is when I meet with a client that, let's say, I don't even know what happened this week, I might ask them what's the last thing they remember and go back then. Sometimes it's very hard for them to do that. That's something I'm curious about. But if they can, I'm really curious if that was a stressful event. I'm really curious what happened that day, the last thing you remember. Um, like, do you remember that very last thing? Like, was it someone saying something or walking into work? Or I really want to see if we can get there, because if it was significantly stressful or triggering, well, that could absolutely lead to a significant dissociative episode. So I don't always want to know what happened after unless it's very important and the client needs to talk about it. I want to know what happened before. And then I can ask questions, right? We can start to ask questions like, oh, does it happen a lot that something really stressful happens and you start forgetting things? Or if a really stressful time comes and you start losing things, like your keys are gone, you had them in your hand, but now they're missing. Um, and how often does it you think this is happening? So that's a really great way to start to flesh out patterns, because that's what we're looking for, patterns. We can't make these decisions right off the bat unless that person has already been diagnosed. Um, but most of the time, they're not. And lots of times, even if they have DID, they're not. I work with clients with DID and clients that have significant dissociation. And most of the time, they have been misdiagnosed. This is another thing to just watch out for. So a client might come in and say, well, I have wicked ADHD. Life is so hard. I forget everything. I lose everything. I feel like I can't keep track of life. Life just feels like impossible sometimes. So obviously that's not dissociation in and of itself. But if this client is coming in with severe complex trauma, I get much more curious if that's a misdiagnosis. I don't know. I need to I need to kind of get to know the patterns, right? I'm also curious if ADHD meds work. So they can help us fixate on something, but do they still find themselves hyperfixating? Do they still find that their time management isn't getting better? Because those medications are not going to treat dissociation. So again, we're looking for patterns. I one of the uh, disorders I mentioned before is OSDD, other specified dissociative disorder. This is not well known, and if any grad school talks about it, first of all, that's amazing. Um, if any grad school talks about it within their general curriculum, that's fabulous, because I'm still not satisfied a if an institution only brings up these very specific trauma related problems if you're on in specific courses that you had to choose, because all clinicians are going to face dissociation, and they're going to face OSDD if they work with complex trauma. So OSDD is different than DID. In DID, people experience the sensation of personalities, completely separate people that they have within them, that have a system, and that they come when that personality comes forward, they step back and they go into an amnesic state. So, and then that personality is completely different, different age, different background, maybe even a different accent. Um, but that's not OSDD. OSDD does have alters, similar as DID, but they're not as separated. They're not, a person doesn't have like extended dissociative states. They do dissociate a lot, and it might be for small bits of time, 5 minutes, 10 minutes, sometimes like an hour. Alters, these kind of alters or parts do step forward, and it's kind of um, this experience of, things were just coming out of my mouth and I couldn't stop it, but I was right there watching it and I just couldn't do anything about it. That's what it's like for an alter to step in. But that it's much more extreme than the typical person who has a part that wants to scream at somebody, right? We all have parts, and we all have moments where we wish we didn't do something. That doesn't mean we have OSDD. This is usually much more significant, much more reactive, where it's causing problems in their lives. So we want to notice if this person seems very labile in session, or they talk about being very labile in their relationships. And this is often referred to as borderline personality, where someone has very disorganized attachment, disorganized relationships, and their relationships keep blowing up, but they can't seem to stop it. They don't understand it, depending on how much awareness they have about this borderline personality issue. Um, but those are classic alters stepping in. All of a sudden, the person is screaming and crying, and they can't stop it, and they kick their partner out, and then they suddenly are crying and sobbing that their partner is gone, and calling them up and saying, please, please, please come back. Those are alters stepping in and out, and their personality is kind of changing a little, and their experiences of emotion are vacillating in this huge way, like, get away from me, please, I hate you, to, oh my gosh, please, please, please come back. So when we notice that, is it a personality disorder? Well, yeah, I guess, but it's people uh, with borderline personality disorder, that's a trauma-related disorder. So that's also what you could call reactive attachment or disorganized attachment. That's what it is. So is it a personality disorder? Well, yeah, if you you add up those symptoms and you put that label on it, yeah. But it's a trauma related issue and an attachment related issue. So it doesn't mean that we don't lean into methods that help them, such as DBT, but they also need other types of therapies, which I will talk about in another video, um, that will help them, that are like somatic types of therapies. OSDD can also look a lot like bipolar 2. If you notice, a lot of people diagnosed with bipolar 2 are people with significant trauma. And predominantly with OSDD, well, with OSDD, DID, any of those are childhood trauma related, chronic, long term childhood trauma, developmental. Bipolar is also a vacillating in moods. So long periods of depression or short periods of depression, and this hypomanic state that can, that can vary. There's a big spectrum in how people experience the intensity of that or what it feels like for them. And the same with the depressive episodes. How deep do they go? That varies for every person, but yet it's this very different presentation. And I'm curious about that when someone says they have bipolar and very significant trauma in their youth, in their early developmental stages, for long-term periods of time. So I get very curious about that, because once again, it's these different presentations happening. And also bipolar and ADHD are differential diagnoses. They're hard to pull apart at times. And people can also be misdiagnosed. Is it bipolar? Is it ADHD? Usually with those people, I'm curious, like, is I'm wondering if this is actually trauma. That doesn't mean that the types of medications that treat these disorders won't work for them, because likely they will. Because I think, as most clinicians know, early developmental trauma does influence brain development and the chemical balances within the body mind. So, and that can be permanent, and it can ruin people's lives. So medication can still be used and applied in order to help someone live a fulfilling life. But it's really important to help people know, well, it's actually not bipolar. And this isn't everyone. I want to be very clear that it's always about patterns and putting puzzle pieces together before we make any quick assumptions. Um, but what if that person was misdiagnosed and always said things were their fault because they have bipolar and they've done all these crazy things, when in fact it was trauma and they were never the problem, but they got blamed? And everyone said, well, you're the problem because you had bipolar and you made all these terrible decisions, or you shut down, or you disappeared, or whatever it was. And that can be life changing for people to know, oh, I didn't just get born with this issue and start creating problems. It was actually other people that instilled this within me, within my body, and within my mind, and then said that I was the problem when I started to respond because I couldn't cope. That is very, very empowering. So if we do come to the place where we can say, this doesn't seem like bipolar to me, this seems like trauma, which I have to say is common, very common misdiagnosis. The same with ADHD, very common misdiagnosis, including in children. Um, but again, doesn't mean medication won't help, and doesn't mean they're not struggling with those symptoms, because they are. So, but we put a pin in it, because we could truly change someone's life if we discovered that together and they thought, oh my God, I've never been the problem. They were always the problem, and then they made me the problem. And that person no longer has to live with that, live with this idea that I am mentally ill, that I'm actually just surviving because of the trauma and I didn't know that. And there's actually a way to heal trauma. It's not just my brain. Because if it's a physical problem that's incurable except to maintain stability, then that really can cause someone to feel pretty hopeless. Sometimes I'm always gearing for people to live fulfilling lives with that, right? Yet, if they can know that it's treatable, then all of a sudden things can open up for them. Life can change. So this has been a video about different aspects of dissociation. It's far from exhaustive, but it is kind of a beginning of that discussion on this channel. And again, I really want you to put out your questions, maybe about the content, anything I was unclear about, maybe something else you'd like to hear about. I'm really interested in that. Again, because this channel is for you. And I want to know about you. I want to understand what you need. And I want to provide that around complex trauma and dissociation. I'm so glad that you were here, and I'm thrilled if I kept you to the end of the video. And if not, I'm still so glad that you came. And of course, as always, subscribing will only help this channel grow so that I can help more clinicians and thereby help more survivors. Thank you so much for being here. All good things.